Welcome to Biology Minds. Today we're going to talk about joints. So, as a culmination to the skeletal system unit, we kind of finish up with joints before we move into the muscular system. So, whenever we're talking about joints, we're talking about articulations, the body movement that occurs at the joint, the way that the bones come together and how they're able to move along each other. Obviously, bones are very hard and they're not really going to move against each other too well. So they need this cushioning and they need these joints, these ligaments, along with these tendons in order to move kind of fluidly against one another. So when we're talking about joint structure, we often talk about the range of motion, or if you're in the medical field, sometimes they'll just say ROM, or they'll document it as ROM. We're talking about range of motion, how far can that joint move, and which kind of direction is it going to move, and how strong is that joint. So as joint strength decreases, as mobility increases, so we see that the joints that are freely movable, they're not very strong, and vice versa is also true. So we see that our hip joint is not really is not too freely movable, not as much as our shoulder joint, but our hip joint is a little sturdier opposed to our shoulder joint, where we see a lot more injuries. We see broken clavicles and issues with rotator cuffs. So think about, the stability is there, but we also are losing strength, and then if the strength is there, then we're losing mobility. So two methods of classifying any joint: either functional classification, which is going to be based on how it functions, its range of motion, and then structural classification is going to rely on just the structure itself, the anatomy of that joint, to really classify the specific joint. There are three main types of classifications when we talk about functional classifications of joints. You have synarthrosis or synarthroses. These are immovable joints, joints that don't move. Then you're going to have amphiarthrosis or an amphiarthroses. They are going to be slightly movable joints. And then for the most part, we talk about these diarthrosis, diarthrosis or diarthroses, and they're going to be our freely movable joints. Structural classifications: bony, fibrous, cartilaginous, synovial. Here are the different types of synarthrosis joints that don't have movement. We've talked about sutures already. Okay, you have gomphosis, which is in the teeth, synchondrosis at that kind of joint that joins the ribs and the sternum, and then you have synostosis. That is also found in the skull as well, as a bony type of synarthrosis. You have amphiarthrosis, which is going to be a syndesmosis or a symphysis. We talked about a symphysis, our pubic symphysis, where our pubic bones are connected, and we see in females that after they have had a child, that this kind of breaks up a little bit in order to have the child fit through the birth canal. So when we're looking at forensic anthropology, we can tell if the skeleton or the person in the patient, they ever had a child through natural birth. And then you have your diarthrosis or diarthroses. These are going to be based on the plane. So are they monoaxial, biaxial, or triaxial? Do they move along one plane, like you think about your knee, elbow, ankle? You have biaxial, they're going to move, ribs and wrists. They kind of have two planes of movement. And then triaxial, we're going to talk about shoulders and hips, that they can move in three different planes. You have articular cartilages. They are going to prevent bones from touching, and we have the synovial fluid, which is going to lubricate and reduce any friction in smooth surfaces. Synovial fluid in synovial joints is there for lubrication, distribution of nutrients, so it's going to diffuse into the synovial fluid and then be distributed throughout that synovial fluid, so that the cells then get the nutrients. Keep in mind that when we talk about cartilage, it is avascular, so we're really relying on that diffusion in order for nutrients to get to the cells. With that being said, cartilage is not going to heal as well, and that's why we see that surgeons are going to have to go in and really fix any issues that we have with ligaments, because that cartilage is avascular. That lack of vascularity also decreases the healing time, and oftentimes we don't see it heal at all because there's just not enough nutrients getting to that site in order to build that cartilage back up. And ultimately, that synovial fluid is also there for shock absorption. Cartilages are going to cushion the joint. We have fat pads that are going to protect the articular cartilages, and the ligaments are there to strengthen the joints. And oftentimes we hear about people getting sprains. Well, we know a sprain isn't a broken bone, but what it really is that ligaments have torn collagen fibers, and it leads to swelling and a lot of pain. And oftentimes they're going to heal on their own, but they take a lot of time, and you have to stay off of it. So when we have sprains, you're going to go to the doctor, and they're going to immobilize it, make sure that you're not moving it. You sprain your ankle, they're not going to tell you, yeah, keep walking on it, it'll get better. They're going to give you a boot, or they're going to have you take weight off of it until it is healed. You have tendons. That's what's there to connect your muscles to your joints, just like ligaments are there to connect bone to bone, or bone to the joints, I should say. And then you have your bursa. Okay, so bursa, it's like a pouch, and it's a pocket of synovial fluid. So a lot of times you'll see that people get bursitis, which is the swelling of the bursae. And this bursa, this fluid-filled pouch, is going to be there to cushion the areas where bones and muscles come together. Factors that stabilize synovial joints prevent injury by limiting range of motion. You're going to have your collagen fibers that we always talk about. That elasticity in there is going to help to limit that range of motion. Articulating surfaces and a meniscus or menisci, other bones, muscles, or fat pads, and then as well as the tendons that are going to be there in articulating surfaces, articulating bones. This is just a general idea of a synovial joint, so this isn't a specific joint that we're necessarily talking about, but just as a hypothetical synovial joint, you're going to have a bone here and a bone here, and then you're going to have this articular cartilage there, and you're going to have this bursa, or this opening where synovial fluid is found, and it's going to be lined with a synovial membrane, and we're going to have this joint capsule. Keep in mind, you still want to remember that we have our compact bone, we have our spongy bone, sorry, this is spongy bone, and we have our compact bone. Okay, we have our diaphysis, our epiphysis. This is our epiphyseal plate, okay, where our metaphysis is. So some of this stuff we should remember. And then this is a sagittal view of a knee joint, where we have our femur superior, inferior is our tibia, and we're going to have the same kind of idea where we have this synovial fluid in here, synovial membrane, and we're going to have this articular cartilage, and this is all in order to really make sure that these bones aren't rubbing against each other, and that they have fluid or easy movement while being bony. It's difficult for them to really move. It kind of helps cushion things so that it's not bone on bone, muscle on bone, or anything like that. Some injuries, we have luxation, which is what we call typically a dislocation. Okay, the articulating surfaces are forced out of position. It can damage articular cartilage. A lot of times, you might have some ligament damage, ligament tears, and the joint capsule can also be damaged. And then you have subluxation, which is really a partial dislocation. Talked about the different planes, the three types of dynamic motion, where we see a gliding motion, angular movement, or rotation. Some terms to know: flexion, okay, when you're flexing, and then extension. Hyperextension is no good. That's going past the anatomical position, past the point that we should be going to. This is just a diagram showing you how you're going to be flexing or extending something. If you go too far, we call that hyperextension. So if you're flexing this arm up, that's flexing. If you're extending it out, that is extension. And that goes for any joint that we're really talking about. You have movements that go away from the body. All right, so when we're talking about it going away, think about like aliens. They're abducting you, they're taking you away. Well, the same thing goes for if you move your body part away from you. That is abduction. And then if you're moving it towards you, that's adduction. Circumduction, this is a circular motion when we talk about triaxial joints. Shoulder joint triaxial, it helps you move in, you can move it in a circumduction. Rotation, you can have a left rotation, a right rotation. Sometimes they'll say inward rotation, outward rotation, depending on which joint we're talking about. Medial rotation, lateral rotation. And here you see with the arm, if you're moving it towards the midline, that's going to be medial. If you're moving it away from the midline, it's going to be lateral or external rotation. With the head, we can say it's right rotation, left rotation, and so on and so forth. We talk about pronation or pronating, and then supination. So if you're, rotates forearm radius over ulna, supination is going to be, your forearm is in the anatomical position where you're standing upright and your palms are out. Here you see supination, all right, anatomical position, and then if you're going to twist it this way, okay, it's going to be pronation. Then you have inversion, eversion, dorsiflexion, plantar flexion. Okay, eversion is away, inversion is inward or towards the midline. You have dorsiflexion, moving it up, and then plantar flexion, where you're dropping your foot. Opposition, reposition, protraction, retraction, more terms that are used to describe movements of the joints, movements of the body. Opposition, retraction, right? If you were to move your mandible backwards, you'd be retracting it. If you're moving it outward, you'd be protracting it. And then you have elevating things or elevation, depression, lowering things, making them move down. And then lateral flexion, where we talk about the bends of the vertebral column from side to side. If you have your vertebral column, you're moving it this way, you're moving it this way. Okay, those are lateral flexions. You're moving them away from the midline. Depression, down, elevation, up, lateral flexion, away from the midline, either way. You have functional classification of synovial joints: gliding, hinge, pivot, condylar, saddle, and ball and socket. Okay, you can go over those in the textbook and really understand which ones are which. You have intervertebral joints, the joints that are in between each of the vertebrae. We call them intervertebral discs. Here you see a vertebrae. This is showing you the ligaments that go along with the vertebrae, and we have these discs right here in between each vertebrae. See our discs. Sometimes we have injuries to these discs, so you have the anatomy. You have your vertebral end plate right here on each one, and then within it you're going to have your annulus fibrosus, and within it you're going to have your nucleus pulposus. And we see a slip disc is going to be a bulge in the annulus fibrosus, invades the vertebral canal. All right. Then you have your herniated disc, where your nucleus pulposus breaks through the annulus fibrosus, and it presses on the spinal cord and the nerves, and that's why you have issues with tingling and loss of feeling, because that herniated disc is pressing on those nerves, which we're going to talk about later in the year. So you have this nucleus pulposus, which is extending through, it's swelling through the annulus fibrosus, and that bulge is then showing. So this is a bulge, and that is going to press on the nerves that are in this vertebral column. Here it shows you a nerve being extended out, and that nucleus pulposus is herniated, and it is pressing against that nerve, causing issues with your nervous system. Shoulder joint, you want to know that it is called the glenohumeral joint. All right, that humerus goes into that glenoid fossa. Elbow joint has its own set of ligaments, and it is there to pad that radius and ulna in connecting with that humerus. Hip joint, okay, it's very strong. It has these ligaments that are layered and they're wrapped all around the head of that femur, and that makes it very strong. We don't really see dislocated hips too often because of this wrapping going on. The knee joint, on the other hand, is not as stable, and that's why we see that there are many issues with ACL injuries, MCL injuries, and ultimately, once upon a time when we were apes, we kind of walked on four, we would climb around. Now that we're walking on two legs and we try to push ourselves in sports that maybe we weren't evolved to play, we see that we're going to have issues with uh, tearing these ligaments that aren't as strong as we hope they'd be. Wear and tear, it's not necessarily that you're not healthy or that you're doing something you shouldn't be doing. It's really just over time, wear and tear. We're working them a little too hard, and eventually they happen to tear because you happen to make some wrong movement. So anterior cruciate ligament is a big one we always talk about. Everyone just calls it the ACL, but the real name is the anterior cruciate ligament. Behind it, we have the posterior cruciate ligament, or PCL. You have the tibial collateral ligament, which oftentimes is called the MCL. And then you have your fibular collateral ligament, which is called the LCL. All right, so tibial collateral ligament or medial collateral ligament, and then you have your fibular collateral ligament or lateral collateral ligament that we talk about. So depending on how you're moving, what sport you're playing, okay, you can tear one of these. And then we have this meniscus, all right, broken into the medial menisci, the medial meniscus and the lateral meniscus to form our menisci. And this is really like a long disc of cartilage that is going to be there to help cushion the bone-on-bone joint. Here we see an inside view of this with the muscles cut away. All right, the back of it, or the posterior. And then we have some aging issues where you have rheumatism is pain, or any type of pain or stiffness of skeletal muscular systems. You have arthritis, all forms of rheumatism that damage articular cartilage of the synovial joint. So when you hear about people talk about arthritis, they're talking about their joints, their synovial joints, their knees mainly. And then you have osteoarthritis caused by wear and tear of joint surfaces. So as you get older, generally we talk about people over the age of 60, but even if someone has been doing a blue collar job, you'll see it in their late 40s, even and into their 50s, where they're going to have this osteoarthritis, this breakdown of their joints. Rheumatoid arthritis is an inflammatory condition where we see it as an autoimmune disease. Your immune system is not working properly, and your body's attacking itself. Gouty arthritis occurs when crystals from uric acid, calcium salts are going to build up. That's another issue. And then some factors affecting the bone strength we talked about: age, physical strength, which can physical stress I should say, which could be a positive thing or a negative thing. Hormone levels, see this a lot in women, and calcium and phosphorus uptake and excretion. We want our calcium and we want our vitamin D so that we can absorb it, and genetic and environmental factors as well. So these are some things to keep in mind as we move forward. All right, this stuff isn't going to go away. You need to understand the anatomy so we can further move on to talk about the muscles and talk about the nervous system and the endocrine system as we learn more and kind of get a full idea of the human body as a whole, as all of these components have to do with one another. So keep these things in mind as we're moving forward.